Can you see the slides?
Yes, po.
Okay. So good afternoon again. So this afternoon we're going to talk about gallbladder and the pancreatic hepatobiliary. So as it is, taking of pictures is and recording of videos is strictly prohibited. This is in accordance with the Data Privacy Act of 2012. So before we go on further, I would like to pay tribute again to my mentors in the field of one of my mentors in the field of hepatobiliary surgery, Dr. Chris Arcilia Sr., a hepatobiliary surgeon par excellence. He's responsible for training me in operating on patients with pancreatic hepatobiliary problems. Now he's already up there in the high heavens. So, the gallbladder. The gallbladder is generally located along the inferior surface of the liver, uh, at least in segment 4 of the liver. It is pear-shaped and it's about 7 to 10 centimeters long. If it's more than that, then you might be dealing with a hydropic gallbladder. And the average capacity of the gallbladder is about 30 to 50 ml and a maximum of 300 ml if fully distended. Now, beyond that, chances are that the gallbladder might rupture because of the increase in the intra-abdominal pressure. So you have 4 parts, or rather 3 parts of the gallbladder: the fundus, body, and the neck. Uh, all are covered by peritoneum inferiorly because the superior part of the gallbladder is attached to the liver, and the gallbladder wall is lined with circular as well as longitudinal and oblique muscle fibers. However, the layers are not well developed, and the gallbladder usually lacks a muscularis mucosa and a submucosa in its layer. As to the blood supply, the gallbladder is supplied by the cystic artery, which comes off from the right hepatic artery in about 90% of patients. And theoretically, the gallbladder is found in the triangle of Calot. Okay, so this is the triangle of Calot, and the triangle of Calot is bounded by the inferior edge of the liver superiorly, the cystic duct laterally, and the common hepatic duct uh, medially. So when looking for the cystic artery, this is where you look for it inside the triangle of Calot. That's the first thing we usually identify before dissecting the gallbladder from the hepatic bed. Okay?
Excuse me po, may mga huli pa daw po na-admit sa waiting room.
Well, dapat kanina pa sila nandun kasi. Okay? As to your venous drainage, most of the gallbladder veins drain into the small veins of the liver, and the large cystic vein, which usually runs parallel to your cystic duct, drains into the portal vein. Okay? Nerve supply of the gallbladder comes from the vagus, and the sympathetic branches through the celiac plexus. Okay? Lymphatic drainage is or are into the nodes along the gallbladder neck and the pericholecystic areas or pericholecystic regions. In patients with acalculous cholecystitis, the swelling and the inflammation of the gallbladder may be secondary to an inflamed pericholecystic node, usually because of infection or inflammation. And this pericholecystic nodes impinges on the cystic duct and develops what we call Biritzis syndrome. Okay? From the gallbladder, we go down to the extrahepatic bile ducts. So we have your right hepatic duct and left hepatic duct. Uh, Anatomically, your left hepatic duct is longer than your right hepatic duct. Now, your right and left hepatic ducts converge to form the common hepatic duct, which is about 1 to 4 centimeters long and about 4 millimeters in diameter. The common hepatic duct is usually located anterior to the portal vein and right of the hepatic artery. Okay? Then the common hepatic duct and the cystic duct converge to form the common bile duct. Uh, the common bile duct or the choledochus is about 7 to 11 centimeters long and it's about 5 to 11 millimeters in diameter. Now it's important for us to know the diameter of the common bile duct because in patients with obstruction or in patients with extrahepatic biliary duct obstruction, either secondary to stone or to a periampullary carcinoma, dilatation of the common bile duct will dictate the possible bypass procedure that we are going to undertake. So if the diameter of the common bile duct is less than uh, 1.5 or 2 centimeters in widest diameter, then we would just do T-tube drainage of the common bile duct. On the other hand, if it is 2 centimeters or more in widest diameter, then we would be better off by doing choledocho enterostomy bypass procedures like a choledocho jejunostomy or a choledocho duodenostomy. Okay? Now, the common bile duct opens into the ampulla of water, which is lined by the sphincter of Oddi and is located in the second portion of the duodenum. This is about 10 centimeters from the pylorus. Okay? Now, the common hepatic duct, or the common bile duct rather, is joined by the pancreatic duct just outside of the ampulla of water. As to the arterial supply of your bile ducts, most of these come from the gastroduodenal arteries, and some would come from the uh, right hepatic artery. We mentioned about the sphincter of Oddi. Uh, it lines the opening of the common bile duct into the ampulla of water. The sphincter of Oddi is about 4 to 6 millimeters long. It controls bile flow and the influx of pancreatic juices, of course, obviously from the pancreas. It also prevents regurgitation of the duodenal contents into the common bile duct. Now, when contracted, uh, the sphincter of Oddi diverts bile back into the gallbladder. Okay? Cholecystokinin causes relaxation of the sphincter of Oddi, thereby promoting the flow of bile into the duodenum from the common bile duct. Now we have some anatomical anomalies of your gallbladder. It might be intrahepatic, meaning to say covered by liver tissue. And we have seen this rather commonly during our surgical procedures. It may be rudimentary. There might be duplication or a duplex gallbladder, uh, other anomalous forms, and for some cases, or it's quite rare, would be an absent gallbladder. We may also encounter an accessory right hepatic duct and an anomalous hepatic artery and cystic artery in about 50% of patients. As to your physiology, again I review because I believe by this time you should be experts in anatomy and physiology. So bile is produced by the liver, usually in the bile canaliculi, and we produce about 500 to 1000 ml of bile per day. Now, the stimulants of secretion would include your neurogenic stimuli, humoral stimuli, and chemical stimuli. Bile is composed of water, uh, electrolytes like your sodium, potassium, calcium, chloride, almost the same as your plasma concentration. Then we have bile salts, your cholate and phenoldeoxycholate acids. Then you have proteins, you have lipids or lipids in the form of cholesterol and phospholipids, and your bile pigments, more commonly your calcium bilirubin. Now, practically, the gallbladder functions as a storage tank. And during storage of bile, it concentrates 80% of liver bile and delivers this bile to the duodenum after uh, a healthy meal during contraction of the gallbladder and relaxation of the sphincter of Oddi. Now, what causes this? Of course, your cholecystokinin, which is released from your duodenal mucosa, stimulation by the vagus nerve, and distension of the antrum of the stomach. Now, all of this will cause gallbladder contraction and relaxation of the sphincter of Oddi, thereby increasing the flow of bile into your duodenum. Okay? On the other hand, uh, splanchnic sympathetic stimulation, your VIPs, and your somatostatin causes or inhibits rather inhibits gallbladder contraction. Okay. Now, what are some common diagnostic procedures or diagnostic laboratory workups that we request for? Very basic would be your complete blood count. This is considering that the patient has a hepatobiliary problem. So you have your CBC, you have your total bilirubin, you have your B1 or conjugated or direct bilirubin, you have your B2 or unconjugated or indirect bilirubin, you have your alkaline phosphatase, your aminotransferases, and your prothrombin time. So if you have elevation of your white blood cell count plus elevation of your conjugated bilirubin plus elevation of alkaline phosphatase and your aminotransferases, this is a diagnostic feature of your cholangitis. On the other hand, if you have an elevated bilirubin plus elevated alkaline phosphatase, this speaks of extrahepatic biliary obstruction. Okay, so we look at the levels of your alkaline phosphatase and your aminotransferases. If by ratio and proportion, the elevation of your alkaline phosphatase is more than that of your aminotransferases, it means to say that in a patient with jaundice, the most probable cause is extrahepatic biliary ductal obstruction. On the other hand, if the patient is jaundiced and the levels of your aminotransferases are more elevated than the levels of your alkaline phosphatase by ratio and proportion, then this will tell you that the main cause of jaundice would be an intrahepatic problem and not an obstruction of the extrahepatic ductal system. Okay, we should be clear on that. By that alone, you would be guided as to what causes the uh, jaundice. Okay, so other diagnostic studies, the most commonly requested diagnostic evaluation or diagnostic procedure would be your ultrasound. It's usually the initial investigation requested by most physicians when faced with a patient with a probable hepatobiliary problem. Now, your ultrasound done by a good sonologist has a 90% sensitivity and specificity in identifying gallstones. In patients with thickened walls like this one, this plus tenderness clinically, this is a clinical picture of cholecystitis. Now, an acute cholecystitis, in patients with an acute cholecystitis, the walls are usually thickened and edematous. On the other hand, uh, in patients with chronic cholecystitis, like this one, the walls are not thickened, but the gallbladder may be contracted also. What are the limitations of your ultrasound? It's not really reliable in patients who are obese, in patients with ascites, and in patients with distended bowel loops. Because if you remember, the ultrasonographic waves do not traverse air uh, that is present inside the distended bowel loops. Okay, the waves usually traverse solid material and the liquid material. Okay, during the older times, we used to request for oral cholecystography. So just for you to know, uh, this is an X-ray procedure done after the patient is made to ingest contrast medium, and the gallbladder will show filling defects, uh, and these are stones. But your oral cholecystography has no value in patients with intestinal malabsorption, in patients with vomiting, in patients with obstructive jaundice, and of course in patients with hepatic failure. We may also request for your biliary radionuclide scanning or your HIDA scan. It makes use of a 99M technetium labeled derivative of your HIDA, which is injected intravenously, and this is usually excreted in the bile. In acute cholecystitis, uh, usually there is non-filling of your gallbladder, but there would be prompt filling of your common bile duct. On the other hand, if you have an ampullary obstruction, there would be filling of your gallbladder, your common bile duct, and there would be non-filling or non-ingress of the contrast medium into the duodenum. Okay. Further on, but rarely done, we may also request for your CT scan. It is less sensitive than your ultrasound in dealing with gallstones, but it is the test for choice in patients with suspected gallbladder carcinoma, in patients with extrahepatic ductal carcinoma, or in patients with pancreatic carcinoma, and in patients with obstructive jaundice. Now, more invasive diagnostic procedures include your PTC or percutaneous transhepatic cholangiography. We do this under the guidance of your fluoroscopy, and it clearly defines the biliary tree anatomy as you would look at the picture. Okay, it is useful in patients with bile duct strictures, in patients with tumors, and in patients with suspected hepatic duct injuries or biliary tract injuries. Okay, we may also request for MRI or MRI pancreatography. Okay, uh, for choledocholitis or for stones within the common bile duct, it has a 95% specificity and an 89% sensitivity. Now, your MRCP is the single non-invasive test for the diagnosis of your biliary tract and pancreatic disease. The only drawback there is it is quite expensive for some patients. So another diagnostic study would be your ERCP or your endoscopic retrograde cholangiopancreatography. Okay. The contrast medium is usually inserted through a duodenoscope or duodenoscopy. The advantage of this would be there would with direct visualization of your ampullary region. Plus, you have a direct access to the distal common duct. And if you find obstruction there, because you have your duodenoscope in, you may insert a stent or you may insert a converting balloon catheter there, and you may harvest the stone during the visiting. Okay? Or you may insert a basket, a stone basket, with the help and guidance of your duodenoscope. Okay? Now, for experts, we find a 90% success rate of being able to extricate the stones. Before going any further, uh, let us try to define some terms. When you say cholelithiasis, this means to say that you have stones anywhere in the hepatobiliary tree. Okay? When you say cholecystolithiasis, this means to say that you have stones in the gallbladder. Okay? When you say choledocolithiasis, this means to say that you have stones inside the common bile duct. Okay? So do not interchange these things because it's important for us to know the difference between a cholecystolith and a choledocolith. Okay? So let's now go to your pathologies. First off would be your uh, gallstone disease or uh, cholecystolithiasis or choledocolithiasis. It occurs in about 11 to 36% of all patients, and the risk factors of developing gallbladder or gallstone problem include obesity, pregnancy, dietary factors, especially diet rich in cholesterol, bronchiolitis, uh, resection of the terminal ileum, any general surgery procedures, hereditary spherocytosis, sickle cell disease, thalassemia, and others. Now, it affects women more than men, and first degree relatives have a 2%, 2 times chance of developing a gallstone problem as compared to the general population. If we review the history of these patients with gallstone disease, most patients remain asymptomatic until such time that the gallstone obstructs the flow of bile from the gallbladder or from the common bile duct. The earliest manifestation would be flatulence, gassiness, or bloatedness, and most of the time this occurs after a heavy meal or even after meals. So this is the early manifestation of a gallbladder problem. During this state, it is hard to differentiate between a patient who is suffering from a gallbladder problem against a patient who is suffering from an acid peptic disorder or peptic ulcer disease. Okay, that's why it's important to review the history and assess every detail of the history. Okay, so 3% symptomatic individuals eventually develop biliary colic or pain per year, and 3 to 5% symptomatic patients eventually develop complicated gallstones. So the question is, for asymptomatic gallstones, when is prophylactic cholecystectomy uh, acceptable? When we say asymptomatic, meaning this means that we only discover patients' gallstones during an ultrasound requested for another cause. Okay, so the old dictum was prophylactic cholecystectomy in asymptomatic patients is rarely indicated. However, uh, for some patients, even with asymptomatic gallstone, we may recommend prophylactic cholecystectomy. And when is this? For older patients, uh, in anticipation of probable complications, that may arise if you don't deal with the stones early. These older patients may develop cholecystitis. Uh, Another indication for prophylactic cholecystectomy would be in patients with diabetes mellitus. Why? Because you have an increased incidence of developing emphysematous cholecystitis in patients with diabetes mellitus. And this is common in male patients within the 40 to 50 years of age range. Okay, and mind you, emphysematous cholecystitis has a high uh, mortality rate that goes along with the disease. Also, prophylactic cholecystectomy is recommended for patients who will be isolated from medical care for long periods of time. For example, patients going on a trip, uh, seamen, or those going in other countries wherein the fear of developing cholecystitis would be there. Okay? Or prophylactic cholecystectomy has also been recommended because in some studies, uh, personalities or persons with gallstones have at least a small incidence or a small percentage of developing gallbladder carcinoma. So we have shifted from the non-surgical management of asymptomatic gallstones to a surgical management of asymptomatic gallstones because of these reasons mentioned. Okay. Now, how are gallstones formed? As we said, your bile salts are synthesized in the liver from cholesterol, and they are conjugated in the liver with taurine and glycine. Now, your bile salts act within the bile as bile acids balanced by sodium. Now, gallstone usually forms because of sedimentation of solids out of the bile or the solution, and it also forms because of the imbalance between your cholesterol. We have this triangle, no? Always remember this triangle. Cholesterol, an imbalance between cholesterol, lecithin, and your bile salts. Therefore, your gallstones are classified based on their cholesterol content. Now, your bile salts usually aid in the digestion and absorption of fat. 95% of your bile acids are usually reabsorbed either into the enterohepatic circulation via the portal vein, and they return as well to the liver. 5% are usually excreted in feces. Now, your one of the bile salts, your bilirubin diglucuronide, is a metabolic product from the breakdown of your hemoglobin, and this substance is responsible for the yellow gold color of bile, and it is converted into urobilinogen in the small bowel. And if you have elevated levels of this, then you have orange discoloration of your urine. Okay? So in Western countries, 80% of the stones are usually cholesterol. Okay, uh, there is supersaturation of bile with cholesterol, and they usually form in the gallbladder. Pure cholesterol stones are usually uncommon, and they account for only about 10% of all cholesterol stones. When we do have pure cholesterol stones, they are usually single, large, with barely smooth surfaces. What would be more common would be your mixed stones with a mixture of cholesterol plus bile pigment and calcium. They are usually more than 70% cholesterol by weight, and they are usually multiple. They have variable sizes like this one. They are hard. They may be faceted or regularly shaped, or maybe irregular. They may be mulberry shaped, and they may also be soft. Some stones may be whitish yellow to green to black because of the decreasing percentage of cholesterol and increased percentage of your bile pigment. By X-ray or by radiographs, your mixed stones are usually radiolucent. the other hand, your pigment stones contain less than 20% cholesterol. Your calcium bilirubinate is responsible for the dark color of the stones, and this is the type of stone that is more common in Asian patients. So we have two types of your pigment stones, either your black pigment stones or your brown pigment stones. Now your black pigment stones account for about 15 to 20% of your pigment stones in Western countries, and this is secondary to the supersaturation of calcium bilirubinate or calcium carbonate and your phosphate, and they are usually small, brittle, they may be black and speculated. Most black pigment stones are secondary to hemolytic disorders and cirrhosis, and they usually form in the gallbladder. Your brown pigment stones, on the other hand, are rare. They're usually less than 1 centimeter in widest diameter. They may be brownish yellow, soft, and mushy. They are secondary to bacterial infection that is caused by bile stasis, and they may form in the gallbladder or bile ducts. Now, your brown pigment stones, as compared to your black pigment stones, are more common in Asian populations, and they may be related to parasitism. Okay? They may also be secondary to strictures or common duct stones with stasis plus bacterial contamination. Okay? We now go to your chronic cholecystitis. Uh, when I say chronic cholecystitis, these are patients who have recurrent attacks of biliary colic, right upper quadrant pain. Okay. Now, if you ask these patients about the earliest manifestation or how it all started, more commonly or more often than not, they will tell you that they had uh, experiences of gassiness or postprandial bloatedness or flatulence after meals. Now, of course, pain is the main manifestation, but once you have this pain, it means to say that you're dealing with the patient with cholecystitis or an inflammation of the gallbladder. Okay, so by physical examination, no, going back to pain, it's usually constant. It may be progressive and episodic. It may be localized in the epigastric region or right upper quadrant. It may also radiate to the right upper back or the interscapular area. It may be nocturnal or it may follow a fatty meal, and sometimes this is associated with nausea and vomiting. When you do your physical examination, you may encounter mild right upper quadrant tenderness, and in between examinations, it may be normal. Okay, the laboratories may also be normal. The gold standard in the diagnosis would be your ultrasound. And management, since it's already a symptomatic case, so this is a picture of your ultrasound you have here. You have the stones there and the caustic shadowing underneath the stones. Okay, so management is cholecystectomy. Two choices or two options: either laparoscopic cholecystectomy or open cholecystectomy. This is usually indicated if you have recurrent attacks of, or strongly indicated if you have recurrent attacks of cholecystitis at least more than 2 times, because this will tell you that you may have sludge inside the cystic duct, and this may be seen during ultrasound. Now, for patients who have continuously uh, or who present with continuous right upper quadrant pain, then of course that is an absolute indication for cholecystectomy already. Okay, and cholecystectomy is also indicated to uh, relieve patients. About 90% of patients are relieved by cholecystectomy, even in an uncomplicated cholecystitis. Now, for diabetic patients, it's an urgent it's an urgent thing, especially for males in the 40 age group. It's an urgent thing. You have to recommend early cholecystectomy for fear that these patients might develop emphysematous cholecystitis, which we mentioned earlier carries with it a high mortality rate. For pregnant women who are symptomatic, we usually recommend the cholecystectomy in the second trimester or during the second trimester of pregnancy. So it's a patient with is the ultrasound of the patient. You have to find there the stones. Okay. Cross-sectional, you find the stones there, gallbladder. So we have the stones there. It's actually one cholesterol stone, which was obstructing the neck of the gallbladder, and multiple spiculated malignant stones. Okay. Now this will be more painful because of the spicules. So memorize the appearance of a gallbladder in a patient with uh, chronic cholecystitis. Okay. So here's another patient with chronic cholecystitis. There are multiple stones and one stone impacted in the gallbladder neck. Okay. Look at the wall of the gallbladder. It's not thickened. It's not edematous. It is usually thin wall. That's called it chronic cholecystitis. We now go to acute cholecystitis. 90 to 95% of this is secondary to gallstone, or that's why we call it acute calculus cholecystitis. 1% of acute cholecystitis is secondary to a tumor obstructing the cystic duct. So you have obstruction. This will be followed by distension of the gallbladder, inflammation of the gallbladder, and of course edema of the wall. So the gallbladder in a patient with acute cholecystitis is usually uh, you have a thick wall there. It is reddish. You may find pericholecystic fluid uh, intraoperatively or fluid collection in your Morrison's pouch. The mucosa may be hyperemic with some areas of necrosis. 5 to 10% of patients with acute cholecystitis present with ischemia, necrosis and gangrene of the gallbladder wall. You may also have a dislodged gallbladder, or you may have gangrenous cholecystitis, wherein the entire gallbladder is gangrenous, or you may have abscesses or empyematous cholecystitis. What are the clinical manifestations? Patients who present with biliary colic that may be unremitting and it may be persistent for several days. This may be associated with fever, anorexia, nausea, and vomiting. And if you observe the patient, these patients usually try to lie still on the bed because every time he moves, the peritoneum gets irritated and it will be very painful for him. When you examine the patient, you may find right upper quadrant tenderness with either voluntary or involuntary guarding. You may also have Murphy's sign. So how is Murphy's sign elicited? With your fingers applying pressure in the right upper quadrant underneath the costal cartilages. You ask the patient to inhale deeply, and this inhalation will be arrested. The patient will stop breathing, the patient will stop from inhaling because of the pain that develops during the application of pressure in that area. So if the patient presents with that, obviously that is Murphy's sign. Vis-a-vis, you have a patient with acute cholecystitis. Okay? Sometimes because of the distension of the gallbladder, you may be able to palpate the right upper quadrant mass. And for some patients, you may find them jaundiced, especially for patients with concomitant common bile duct stones or for patients with Merici syndrome. So ano nga ulit yung Merici syndrome? It is cholecystitis that has developed from an extraluminal obstruction of your pericholecystic lymph nodes. Okay, so as your laboratories, we request for CBC, basic, and your liver function tests. Ang CBC may show mild to moderate leukocytosis, while on the other hand, your liver function tests may even be normal. Now, as you mentioned again earlier, adults with diabetes mellitus, they may present with subtle manifestations. You may even have an untender gallbladder, but you have to be worried. You have to be worried about this because this may cause a 10% death rate for these patients. Okay. Diagnosis, the same. Ultrasound is the most useful, it's the gold standard there. It has a 95% sensitivity and specificity. It will usually show a thick-walled gallbladder, with pericholecystic fluid, okay? And sometimes even the sonologist may be able to elicit sonographic Murphy's sign. We may request for a HIDA scan, but a normal HIDA scan does not entirely exclude acute cholecystitis. A CT scan may also be requested, but it is less sensitive than your ultrasound. So treatment, initially supportive, we build up the patient, we try to bring back the patient to optimal. We give IV fluids, we give antibiotics that will cover for gram-negative aerobes and anaerobes, and of course we try to manage the pain. The clue there is we advise early cholecystectomy at least within 1 to 3 days from the time of admission. Laparoscopic cholecystectomy is preferred. However, it carries with it a conversion rate of about 10 to 15%, especially so if you have a gangrenous gallbladder. Now, for patients who are not fit or who are not healthy enough to undergo cholecystectomy, we may perform percutaneous cholecystostomy or open cholecystostomy under local anesthesia. Now, the objectives of which are to drain the infected vial uh, while building up the patient and preparing the patient for a more definitive procedure. Okay? If there's no improvement after this will tell you that you might be dealing with a gangrenous or a perforated gallbladder. That's why, regardless of the patient's clinical condition, we have to go in and perform the definitive procedure. So again, just to show you the difference between chronic cholecystitis, you don't find any inflammation there against acute cholecystitis. Okay? Gallbladder is reddish, thick-walled, and tense. We may also encounter gallbladder hydrops or markedly distended gallbladders. They may be long. The longest that I operated on was about 12 point something inches long. And it was found in a child who's about 12 years old. So we thought this child presented with signs and symptoms of acute appendicitis because the tenderness was in the hypogastric area in the right lower quadrant. But when I opened up the patient in the right lower quadrant, I found the fundus of the gallbladder there. So I had to do a midline incision and go after the gallbladder underneath the liver. Okay. We may also encounter acute gangrenous cholecystitis in some islands of gangrene. Okay. So the same management, cholecystectomy. Or we may also encounter perforated cholecystitis. Okay. Now, one interesting case I've had was uh, the development of a fistulous tract between the gallbladder and the hepatic flexure of the colon. Now, theory has it that this patient may have had acute cholecystitis before, and because of the inflammation, he might have developed uh, a necrosis in the inferior part of his wall, gallbladder wall, and it subtly perforated and developed a fistulous tract between that perforation and the hepatic flexure. Okay, so this is the gallbladder. This is the hepatic flexure of the colon, and that is the fistulous tract. So we did cholecystectomy, and then we repaired. Since there was no spillage, we just repaired the mouth of the fistulous tract on the side of the hepatic flexure. We may also encounter patients with gallstone ileus. Now, this patient probably had common duct stones or a gallstone that was able to find its way through the ampulla of water into the duodenum. But unfortunately, that is where it grew in size, on the ileum, along the ileum. So this patient we manifested with signs and symptoms of obstruction because this gallstone was impacted in the ileocecal valve. Okay? We may also encounter patients with inflammation of the gallbladder with no stones, and we call that a calculus or a calculus cholecystitis. This usually develops in critically ill patients. The cause is unknown, but we encounter gallbladder distension plus bile stasis plus ischemia. These patients may develop ischemia also, even if they don't have stones. So clinical manifestations are the same as for patients with calculus cholecystitis. They may manifest with fever, leukocytosis, elevated levels of bilirubin, and elevated levels of alkaline phosphatase. As your diagnosis, gold standard is still ultrasound. You may do your CT scan and your HIDA scan. Now, HIDA scan is rarely done nowadays because of the sensitivity of your ultrasound. So treatment is either we do ultrasound or CT guided cholecystostomy, insert a needle there, drain the infected bile, okay, and then temporize the procedure until such time that the patient has been stabilized. Because most of these, as we mentioned earlier, most of these calculus cholecystitis usually develop in critically ill patients, heart patients with heart problems or stroke patients. So we have to stabilize them first before going in or before performing open cholecystostomy or cholecystectomy. Okay? Going lower, we have choledocolithiasis or stones inside the common bile duct. Now, this usually develops in 6 to 12% of patients with cholecystolithiasis, and the incidence increases with age. 20 to 25% of patients who are more than 60 years old with gallstones in the gallbladder usually develop choledocolithiasis. So we either have primary common bile duct stones, secondary duct stones, retained stones, and recurrent stones. So when we say primary common bile duct stones, these are stones that form primarily in the bile ducts. If you look at these stones, they usually conform to the shape of the bile ducts such that they are usually elongated. Okay? On the other hand, when we say secondary ductal stones, these usually form in the gallbladder and migrate to the common bile ducts. When you look at them, they are usually rounded or spiculated and not elongated. When we say retained stones, these are patients who have undergone cholecystectomy or choledocolithotomy, and we again discover stones within 1 year from the surgery. Okay, so retained stones pa din yun. On the other hand, when we say recurrent stones, These are patients who have undergone cholecystectomy or cholecystectomy, and we discover stones more than 1 year from the time of surgery. Okay? Now, patients with cholecystectomy sometimes most of them are asymptomatic, and we call them silent stone formers. Uh, the stones may be discovered incidentally, but for some patients, they may present with obstructive jaundice, and the obstruction may either be complete or incomplete, such that the jaundice may either be transient or deepening. Now, the problem there is most of these patients will develop cholangitis or even gallstone pancreatitis. Uh, Pain is a common stay. Uh, Usually biliary colic. It may be intermittent or constant. Patients may also manifest with nausea, vomiting, even anorexia. When you do your physical examination, you may or you may not have epigastric or right upper quadrant tenderness. But most of these patients may present with ictericia or jaundice. Another thing that you should ask for is the discoloration of the urine. Most of them will present with orange colored or tea colored urine. Okay? The diagnosis, you may request for CBC and your liver function tests. Your CBC may present with mild leukocytosis. On the other hand, your liver function tests will present with elevated levels of bilirubin, uh, alkaline phosphatase, and your transaminases. However, one-third of patients may manifest with normal liver function tests. Ultrasound may be requested. It may show, of course, your gallstones or common bile duct stones. For patients with uh, at least gallstones and the CBD is more than 8 millimeters and they present with pain and jaundice, more often than not, there might be a CBD stone that was not seen by ultrasound. So remember that. If you encounter patients uh, with gallstones, CBD more than 8, if you have a CBD, lalo if it's more than 1.5 centimeters, and the patient is jaundice with pain, uh, always take into consideration the possibility of that patient having common bile duct stones. Okay? So we may request for MRC. It has a 95% sensitivity and 89% specificity. You may request from ERC, which is the gold standard, extrahepatic retrograde cholangiopancreatography. Okay? It's a gold standard. It is both diagnostic and therapeutic, especially if you have a scope there. As we mentioned earlier, you may be able to insert a stone basket or Fogarty catheter, and then harvest or extract the stone. Or if you can't do that, then you may do stenting. Okay? Insert a small stent to bypass the point of obstruction. A PTC is rarely used. Okay? So here's a picture of a patient with a solitary gallstone and two polydocal stones. So treatment, a less invasive approach would be performing an extrahepatic retrograde cholangiopancreatography plus sphincterotomy plus extraction of the stone followed by laparoscopic cholecystectomy. Now sometimes this may seem funny because if you do open cholecystectomy, you would just have one procedure there. Open up, take out the gallbladder, take out the stone inside the uh, common duct, then get out. But here you do your ERC first, then you do your sphincterotomy, stone extraction, then you still have to open up the patient by laparoscopic means. Okay. Another option would be if you're an expert in doing it, you may do laparoscopic cholecystectomy plus laparoscopic common bile duct exploration, extraction of the stone, and then insertion of a tissue drainage. Or you may do open cholecystectomy plus intraoperative cholangiography plus common bile duct exploration, extraction of the stone, plus T-tube drainage. Okay. Now, during cholecystectomy, there are uh, absolute and relative indications for common bile duct exploration. But before going to that, so a question here would be, what if you fail to extract the stone? Because some stones may be so impacted that you already have fibrosis that have formed around the stone. And if you insist on trying to extract it, you may do more harm than good. So that is the question. What if you are unable to extract the stone? Then the best option would be to bypass the obstruction, okay? By doing a proximal choledochoduodenostomy or anastomosing the common bile duct of the duodenum, or you may do a cholecystojejunostomy UNY procedure. Okay? So my personal preference would be doing a choledochojejunostomy UNY procedure. Or if I haven't taken out the gallbladder first, that would be another option to do a cholecystojejunostomy UNY procedure. Now, going back, what are the absolute and relative indications for doing common bile duct exploration during cholecystectomy? So the absolute indication for CBD or for doing CBD is if you were able to palpate a stone within the common bile duct, or if you have discovered the stone within the common bile duct preoperatively by means of your ultrasound, and intraoperatively if you were able to discover the stone by palpation or after doing your intraoperative cholangiography. Now, on the other hand, what are the relative indications for doing your common bile duct exploration? If you have a dilated common bile duct, which is more than 1 centimeters in widest diameter, 1 centimeter in widest diameter, if you have multiple but small stones within the gallbladder, if you have elevated liver function tests, if you have obvious manifestations of obstructive jaundice, or if you have jaundice and pancreatitis in one patient. Okay? Now, for retained or recurrent common ductals or common bile duct stones, we may do ERC or sphincterotomy, ERC plus sphincterotomy plus harvesting of the stone. So that would be an option. So we keep on mentioning T-tube. What is the purpose of a T-tube? Why do we have to insert a T-tube? Now, first off, the T-tube is inserted in the common bile duct because we have this will be used as a stent. Okay, stent in the areas where we perform the common duct exploration. Why? Remember that you are uh, uh, exploring the common bile duct with blood instruments that may cause inflammatory reaction inside the mucosa or along the mucosa of the common bile duct. And after inflammation, you may be forming strictures, okay, as part of the healing process. So to prevent obstruction or to prevent formation of these strictures, we insert a T-tube as a form of conduit and as a stent in the areas where you perform the common bile duct. Okay? So during exploration, we open up the common bile duct, insert a stone forceps proximally first, assess the right and the left common bile ducts or common hepatic ducts, whether there are stones or not. Then after performing exploration of the upper area, we perform exploration of the lower areas of the distal common bile duct. Insert the stone forceps. Of course, we do this with the assistance of our other hand outside of the CBD, palpating from outside. Okay? Then we extract the stone. Then we insert the T-tube, anchor it, and then exteriorize the T-tube separately uh, in the right upper quadrant. Okay? When do we remove the T-tube? Anywhere between 14 days post-operatively to 30 days post-operatively. Okay? Why? Because we have to be sure that a fistulous tract, temporary fistulous tract has been formed. between the common bile duct and the skin before we remove the tissue. Otherwise, if we remove the tissue right after, bile may leak into the peritoneum because that tract has not been formed yet. Okay? Let's now go to your cholangitis. It's one of the dreaded infection of your hepatobiliary tree. It usually follows cholelithiasis. You have an ascending bacterial infection. So what is the pathophysiology behind it? You have a CBD obstruction either produced by gallstones, tumors, or even worms or helminths. Plus, because of the stagnation of the bile, bacterial contamination sets in. And then this bile, of course, refluxes and regurgitates and enters into the enterohepatic circulation via the portal vein, and then it spreads systematically, producing a systemic infection in the form of cholangitis. And what are the etiologic agents? You have your Escherichia coli, your Klebsiella pneumoniae, your Streptococcus faecalis, and your Bacteroides fragilis. What are the clinical manifestations? The patients may manifest with mild, intermittent, self-limiting clinical manifestations, but they may progress to fulminant and life-threatening manifestations. So, speaking of cholangitis, we have what we call your Charcot's triad or your Raynaud's pentan. The Charcot's triad is a combination of fever, right upper quadrant pain, and jaundice. Okay. On the other hand, Raynaud's pentan is Charcot's triad plus signs and symptoms of septic shock like hypotension and mental status changes or disorientation. Okay, so it's worse. So, as to your treatment, as to treatment, for diagnosis first, you may request for CBC. You may encounter leukocytosis with elevated liver function tests. Ultrasound is diagnostic. It's gold standard. It may help you detect whether the infection is caused by stones or tumor. You may also request for ERC or PTC. Again, it has a diagnostic and therapeutic value. It allows you direct visualization of the acts. Plus, it allows you to extract the stones and drain the infected bile. Okay? So you may also request for CT scan or MRI. Now, your CT and your MRI has the advantages of telling you whether there are ductal dilatation elsewhere or there are pancreatic masses or even periampullary masses. Okay? Now, treatment, initially we have to keep the patient at optimum, uh, taking care of fluid and electrolyte resuscitation, giving them IV antibiotics that will cover for your gram-negative aerobes and anaerobes. Uh, for non-responders, and this accounts for about 15% of patients with cholangitis, we may do emergency biliary decompression. Okay, CT-guided or ultrasound-guided aspiration of the affected bile via cholecystostomy. Or we may also do ERC plus cannulation and then drainage of the bile. However, for some patients who do not respond, we may do emergency surgery, common duct exploration, extraction of stone plus tissue drainage. Cholangitis carries with it 5% overall mortality rate. Next would be biliary pancreatitis. Now, choledocholitis may be associated with pancreatitis. So the pathology there is that these patients have a probable impacted pancreatic duct stone, or we have what we call the common channel syndrome. Common channel syndrome because it has been hypothesized that the temporary obstruction is caused by a passing stone that has dropped from the common bile duct into the uh, sphincter of Oddi area, periampulary area. So the passage of the stone may cause inflammation of that area, causing temporary obstruction of the uh, flow of the pancreatic juices. Okay? So diagnosis, ultrasound may be very helpful, or you may request for your pancreatic enzymes also aside from your liver function tests. The best pancreatic enzyme to request for would be your lipase because it is more specific for your pancreas, unlike your amylase. Your amylase may be elevated by other pathologies or by other conditions like peptic ulcer disease, pregnancy, even mumps. Okay? You may encounter elevated amylases. So again, specifically request for your lipase. Treatment for severe pancreatitis, we usually do ERC plus sphincterotomy plus extraction of the stone. Uh, but after the patient has been stabilized, we do same admission cholecystectomy, intraoperative uh, cholangiography, or preoperative ERC. So I would rather go for open cholecystectomy, do an IUC, then go after the stone. This will allow me direct palpation and visualization of the pancreas. So here's a patient with biliary pancreatitis. If you would note the calcium deposits lining the anterior surface of the pancreas, and the pancreas is markedly dematous. CT scan of this patient here, okay, and you see the stone there. You may also encounter recurrent pyogenic cholangitis. This is usually endemic in Asia, affecting mostly the Chinese population. Etiology includes E. coli, Klebsiella, Bacteroides fragilis, Enterococcus fecalis. Okay. You may also encounter Pneumorchis sinensis, Pistorchis vivereni, and Ascaris. So what happens? Uh, Bacterial enzymes cause bilirubin deconjugation, forming bile sludge, uh, and this combination of bile sludge with bile pigment stones or brown pigment stones may cause later on obstruction, okay, and increase in the colonization of the bacteria. If this uh, process is recurrent, patients may end up developing cholangiohepatitis. The clinical manifestations include epigastric pain, right upper quadrant pain, fever, jaundice. Now, what is pathognomonic there is the recurrence of these symptoms. Okay? So, diagnosis, you may request for ultrasound, MRCP. Now, your ultrasound may show stones or pneumophilia, air within the walls of the gallbladder or common bile duct. Okay? You may also request for MRCP and PTC or percutaneous transhepatic cholangiography. So treatment, you have to remove the stone, remove the debris, and relieve the sutures. So most of the time, we either leave a stent there, or we may do a direct hepatico-jejunostomy, Roux-en-Y maneuver, okay, or Roux-en-Y procedure. So this is the roux limb and the Y limb, and that is the common hepatic duct stump. The venous is the roux limb with the common hepatic duct stump, either by an end-to-side anastomosis, but never an end-to-end anastomosis. Okay. Then we have your choledochal cysts, or these are congenital cystic dilatations of the intrahepatic and extrahepatic bile ducts. It is a rare condition, and we have different classifications, but the most commonly used would be your modified Alonso-Lake classification. Uh, the incidence is 1 out of 100,000 to 1 out of 150,000 population. Females outnumber males in terms of incidence by 8 times. So the Alonso-Lake classification for type 1, it's a diffuse enlargement of your common bile duct. Type 2, you have diverticular formation of your common bile duct. Type 3, you have cystic dilatation of the intraduodenal common bile duct. Type 4 is cystic dilatation of the extra and intrahepatic bile ducts, while type 5 is otherwise known as Rollis disease, and you have multiple intrahepatic bile duct cysts. Okay, so those are your choledochal cyst variety according to Alonso-Lake classification. We also have modified Tudanis classification. Practically, it's almost the same. So your clinical manifestations, patients may present with jaundice and cholangitis. Less than 50% present with the clinical triad of abdominal pain, jaundice, and a palpable mass in the right upper quadrant. So diagnosis, we request for an ultrasound, CT scan, or an MRC. So treatment for types 1, 2, and 4, we usually excise the extrahepatic ducts. We do cholecystectomy, and then we anastomose the proximal hepatic duct, common hepatic duct, with the jejunum via a Roux-en-Y fashion. For type 3, we only perform sphincterotomy to allow drainage of bile through the fusiform dilatation of the intrahepatic common bile duct or intraduodenal common bile duct. For type 5, may do segmental resection of the liver with the most number of ductal cystic malformations. Okay? One of the most common or dreaded sequelae would be development of cholangiocarcinoma in 15% of patients. We may also encounter stenosis of the sphincter of Oddi. In benign stenosis, this is usually associated with inflammation, fibrosis, or muscular hypertrophy. So clinical manifestations, these patients will manifest with episodic pain with abnormal liver function tests. They may also manifest with recurrent jaundice and pancreatitis. The diagnosis, we request for ultrasound and ERC. Uh, this may show dilated common bile duct with difficult cannulation. So treatment, we usually perform sphincterotomy at the 11 o'clock position. Okay, so why 11 o'clock position? To avoid the gastroduodenal artery that usually passes underneath. Okay? We may also encounter bile duct strictures, and the most common cause would be iatrogenic or from operative injury during the common bile duct exploration. Okay? This is also commonly related to laparoscopic cholecystectomy with blind clamping, the clamping of the alleged cystic duct without proper identification of the common bile duct. So it is best first to identify your anatomy before applying the staplers there. Okay. They may also develop fibrosis as a result of chronic pancreatitis, CBD stones, cholangitis, Medici syndrome, sclerosing cholangitis, cholangiohepatitis, and biliary enteric anastomosis. Okay? So what are the sequelae there? Patients may develop recurrent cholangitis. They may also develop secondary biliary cirrhosis and even portal hypertension. So, as for clinical manifestations, you have recurrent episodes of cholangitis, no? Recurrent fever, right upper quadrant pain, jaundice, gagaling, and then the conditions recur. So, diagnosis, you have ultrasound, uh, CT scan, or MRI, MRC. You may also request for a PTC and ERC, which are again both diagnostic and therapeutic. So, treatment, we may do endoscopic dilatation, no? Via your PTC, insert the scope, identify the ampoule of water, insert bourgeoisie there, or bourgeois, okay? Or just leave behind a stent there, okay, to bypass the obstruction or as a conduit underneath the stricture. Or we may do a right out open procedure, do a hepatico-jejunostomy or choledochojejunostomy, 2NY, or hepatico-J, which is of course, the gold standard in treatment, and usually have an 80 to 90% success rate. Because the problem of stenting, it has time limitations. Usually, in 10 to 15 years, the stent usually obstructs, so we have to reopen up the patient again and then change the stent. Okay. Now, gallbladder carcinoma is a rare condition, but it's an aggressive condition with poor prognosis. It affects older adults. You only have a 5% 5-year survival rate there. And as to your incidence, it is the fifth most common gastrointestinal malignancy. Uh, it accounts for about 2 to 4% of all malignant gastrointestinal tumors. It affects females more than males, and the peak incidence is at during the seventh decade of life. Well, your gallbladder carcinoma has been discovered in about 1% of all cholecystectomy patients in the United States. And you have a high incidence of gallbladder carcinoma in native populations of the United States, Mexico, and Chile. It affects about 75 to 100,000 Native Americans with gallstones, or about 2.5 out of 100,000 US residents. We have encountered uh, number of patients with gallbladder carcinoma locally, and most of these have been misdiagnosed as having cholecyst or calculus cholecystitis. But when we opened up the patients, the thing that were misinterpreted as stones were, in fact, uh, the mass of the cancer itself. Okay? So, etiology, 90% of patients have gallstones. Uh, this also tells us that you have a 20-year risk of developing carcinoma, and this is about 0.5% of this possibility for the overall population, and 1.5% of patients in the high risk group, including patients with gallstones, elderly patients. Now, this is one of the uh, this is one of the reasons why we recommend early cholecystectomy even in patients with an asymptomatic gallstone. Okay? It may also develop from polyps of the gallbladder, especially if uh, the stone is more than 1 centimeter. And 20% are associated with the calcified or porcelain gallbladder. As to your pathology, adenocarcinoma accounts for 80 to 90% of this type of cancer, uh, with papillary more than nodular, or commonly more than tubular. We also encounter metastatic carcinomas from your lymphatics, okay, like the cystic duct node of Calot or pericholecystic node, or you may also encounter involvement of your pericholedocal nodes, or from venous drainage to segments 4 and 5, or from contiguous spread, from adjacent tissues. Intraoperatively, 25% are localized to the gallbladder wall, 35% have regional involvement, regional lymph node involvement, or liver metastasis, and 40% of patients are found to have distant metastasis. Okay, so manifestations, again, you have the same manifestations as cholecystitis, and more than 50% are not diagnosed before surgery. In other words, they are usually incidental findings during surgeries for alleged gallbladder stones. Okay, so gold standard in the diagnosis would be your ultrasound, which will show a thickened, irregular gallbladder that may have been replaced by the mass itself. Uh, and your ultrasound has a 70 to 100% sensitivity. CT scan is requested to assess metastasis, and ERCP may be helpful because it may be both diagnostic and therapeutic. So this is a young patient, I think a 40 plus, 46, 47-year-old female patient who was diagnosed as having uh, gallstones or cholecystolithiasis, and she was symptomatic. So when we opened up the patient, it was gallbladder carcinoma, and we have the nodules there. Okay? So treatment is cholecystectomy. Although for some patients, the only thing that we could do is do stenting for the obstruction. Uh, for T1 lesions, as long as we were able to take out everything, take out the we would have a margin, normal margin around the gallbladder. For T1 lesions, the survival rate is usually 100%. Overall 5-year survival rate. For T2 lesions, we may do extended cholecystectomy to include the dissection up to segments 4 and 5 of the liver, and we do lymphadenectomy for the pericholedocal and pericholecystic nodes or Charcot's nodes. Okay. Now for T3 and T4 lesions, we may do cholecystectomy with or without hepatectomy. But most of the time, when we encounter our T3 and T4 lesions, we already have metastases to other sites inside the peritoneal cavity. Now remember that chemotherapy and radiotherapy are of no value in the in patients with gallbladder carcinoma. Okay? So prognosis, uh, by the time the patients are operated on, most of them have unresectable diseases. Okay? The 5-year survival rate of all patients with gallbladder carcinoma is less than 5%, with a median survival rate of 6 months and a median survival rate for patients with distant metastases as 1 to 3 months, or is 1 to 3 months. Okay? That deadly. Now for patients with T1 lesions who have undergone cholecystectomy, survival rate may increase up 85 to 100%. For T2 lesions, patients with T2 lesions who have undergone the right surgery, survival rate may increase to 70%. If a recurrence rate is high, if they do recur, they recur in the liver, the celiac area, and the retropancreatic nodes. So, what does this tell us? For patients with recurrent gallbladder carcinoma, the prognosis is very, very poor, and these patients usually die because of biliary sepsis or liver failure. Okay? This is a patient with a T2 lesion, gallbladder carcinoma. So we resected part of the liver and we did extended cholecystectomy to include part of the liver and pericholecystic nodes. Okay. So cholangiocarcinoma. Uh, Cholangiocarcinoma is a rare tumor arising from the epithelium anywhere in the biliary tree. Two-thirds of these lesions are located in the hepatic duct bifurcation, and we call these tumors your Klatskin tumor. No? More commonly, along this area. Okay, many patients have advanced disease at the time of diagnosis because they present with jaundice. And when they have jaundice, it will just tell you that there's an obstruction there in the hepatic or hepatobiliary tree. Now, curative surgery, because of that, curative surgery is not warranted most often. All we could do is bypass the point of obstruction, no? By doing palliative surgery and draining the bile, at least to prevent the patient from developing liver failure and cholangitis. Now, death occurs in 1 year for unresectable diseases. Now, cholangiocarcinoma's incidence is about 0.3% of all patients who have undergone autopsy. Uh, and it accounts for 1 out of 100,000 cases in the United States. So you have here your types of cholangiocarcinoma, your bismuth 1 affecting the entire common hepatic duct, bismuth 2 affecting uh, the entire common hepatic with uh, distal areas of your right and left common hepatic usually. Yan. Ito yung Klatskin tumor. Okay. Then bismuth 3A, almost the entire right, and bismuth 4. Okay. Both the right and left almost entirely affected. The risk factors, you have primary sclerosing cholangitis, choledochal cysts, ulcerative cholangitis, stones within the intrahepatic ducts or hepatolithiasis. Even your surgical extirpation or surgical procedure itself may cause cholangiocarcinoma. No? Your biliary enteric anastomosis may cause cholangiocarcinoma in the long run. Then you have the biliary tract infection from Clonorchis sinensis, and of course, in patients with chronic typhoid who are chronic typhoid carriers. Uh, Osteopathology, the common histologic type is your adenocarcinoma. 95% of these are adenocarcinomas. As their clinical manifestation, patients will present with painless jaundice, and this is the most common manifestation. They may present with pruritus, even kernicterus. They may present with right upper quadrant pain, uh, anorexia, fatigue, and weight loss. So diagnosis, ultrasound and CT scan will help you a lot. They will give a lot of information. Now, for perihilar tumors, they will show dilated intrahepatic ducts, a collapsed gallbladder, and distal extrahepatic ducts. Okay? For distal tumors, they will show dilated intrahepatic and extrahepatic ducts, like this one. IOC during surgery may be helpful as a guide. PTC and BRC are both diagnostic and therapeutic because you could attempt to insert a stent and bypass the obstruction. MRI will be helpful in assessing metastasis. For treatment, uh, you may do surgery, surgical excision ideally. However, the problem there is when we open up the patients, at least 50% of them have advanced disease already during the surgery. So all we could offer them would be a bypass procedure, either a cholangio jejunostomy or hepatico J. Depends on the location. But for advanced clot scheme, all that we could offer would be a cholangio jejunostomy fusing between the right and left duct, which the anastomosis with the jejunum. Okay? Now for distal tumors, more distal tumors, we could bypass them doing choledoco, proximal choledoco jejunostomy or hepatico jejunostomy, Roux-en-Y fashion, or uh, my usual practice is when I encounter patients like this, I do not take out the gallbladder first. I try to assess the extent of the tumor, and if there's nothing I could do, the tumor is unresectable, then I make use of the gallbladder as a bypass platform, and I anastomose the gallbladder to the jejunum, okay, to bypass the obstruction. Or we may do percutaneous or endoscopic stenting. The operative mortality is high, especially for perihilar disease. And we should remember that there's no role for chemotherapy nor radiotherapy. Now, for your prognosis, the 5-year survival rate is accordingly for resectable perihilar carcinomas, it's 10 to 30%. Now, those with clean margins where you were able to resect the tumor may rise up to 40%. Now, for distal carcinomas, you have a higher survival rate, 30 to 50%, because most of these are, it would be easy to perform surgeries for distal cholangiocarcinomas than proximal cholangiocarcinomas. Well, easier said than done actually. The median survival rate is 32 to 38 months. Now, for unresectable disease, the median survival rate is 5 to 8 months. And for unresectable disease that have not been bypassed, the most common cause of death would be sepsis secondary to cholangiohepatitis or cholangitis. So let's now go to your operative interventions. When we say cholecystostomy, this means to say decompression of the distended or inflamed hydropic or purulent gallbladder. You may do it by ultrasound guidance through the liver with or using a pigtail catheter. Okay? This is the procedure of choice. Or we may do an open type cholecystostomy. So this is a patient with uh, cholangitis. Initially, we did cholecystostomy, inserted the tube there, drained the infected bile, and then this would allow us to maneuver around the gallbladder and allow us to gain access to the common bile duct. Okay? For cholecystectomy, either open or laparoscopic cholecystectomy. So when we say cholecystectomy, it is the procedure to done to take out the gallbladder. Okay? So either open or laparoscopic. Your open cholecystectomy is safe and effective for both acute and chronic disease, while your laparoscopic cholecystectomy, this emerged as a treatment of choice since 1987. And the main indication there would be for patients with symptomatic gallstones. Uh, Contraindications include uncontrolled coagulopathy and stage liver disease. Now, nowadays, we have shied away from laparoscopic cholecystectomy because of the aerosolizing, the danger of aerosolizing air inside the operating room. Tapos may COVID pala yung pasyente. So, because when we do laparoscopic cholecystectomy, we infuse air into the belly so that the abdomen would be collapsed, and this would allow us to dissect the gallbladder freely. The abdominal wall will be collapsed. But that air may be the nidus for aerosolized virus. Okay? Conversion rate is 5% for elective laparoscopic cholecystectomy and 10 to 30% for emergency laparoscopic cholecystectomy. Now, safe surgery, when we schedule the patient for laparoscopic cholecystectomy, we have them sign two consents. One for laparoscopic cholecystectomy, and in case we fail with laparoscopic cholecystectomy, we convert it to open cholecystectomy. Okay, so the patient has to sign that consent also. Now the problem there is if we have difficulties or if we encounter difficulties in doing your laparoscopic cholecystectomy, when should we convert to an open cholecystectomy? The gold standard is 40 minutes. If after 40 minutes you haven't dissected your gallbladder yet, it will be best and safer for the patient if you convert it to open cholecystectomy than continue on doing or attempting to dissect the gallbladder by laparoscopic means. Okay, so 40 minutes. Well, unfortunately, this is not strictly followed by other surgeons. So preoperative preparation, we request for baseline CBC plus liver function tests, including your prothrombin. So for open cholecystectomy, patient is placed in a supine position. We used to do the older Cocker incision. It's a right oblique subcostal incision. But now I'm doing the right paramedian incision along the lateral border of the rectus muscle directly above the gallbladder. So it's easier to retract. We may do a small incision, open cholecystectomy, making use of a 1-inch incision, open cholecystectomy in stenic or hypostenic patients. So again, open cholecystectomy. Okay. So two ways of doing it, either through a retrograde pattern or an antegrade fashion. When we say antegrade fashion, we first identify the cystic duct and the cystic artery, ligate the cystic duct and cystic artery, and then mobilize or dissect the gallbladder from the liver bed, starting from the neck going upwards into the fundus. When we say retrograde cholecystectomy, we start with the fundus, going down to the cystic artery and the cystic duct. Okay? So here we're doing a retrograde cholecystectomy starting with the fundus. So again, gallbladder being mobilized from the liver bed. So after complete mobilization, we should assure that there is no bleeding in the liver bed, okay, before closing up. So this is the gallbladder, that's the stone. So to compare an open surgeon from a laparoscopic surgeon, no pun intended. I would rather be this. So for lap cole, we have 4 to 5 incisions. The first thing we do is incise underneath or around the periumbilical area, insert the scope, okay? Insert the trocar for the scope, and then visualize the area of the gallbladder or area around the gallbladder, and then use the light as a guide to where we incise or we make skin incisions where we could insert the other instruments. Okay, so it's usually a 4 to 5 incision laparoscopic cholecystectomy procedure. Okay, so that's how we do it. This is the laparoscope. These are the instruments and the grasper inside. So just to show you. Then we have intraoperative cholangiography. We insert a tube or feeding tube through the cystic duct into the common bile duct, and then inject contrast media into that tube down to the common bile duct. Okay, this will help us assess the hepatobiliary tree. So again, routine IOC is done if CBD we have identified common bile duct stones, and this is usually in about 7% of patients. Selective IOC is done in patients with abnormal liver function tests, patients with pancreatitis, patients with jaundice, patients with dilated common bile ducts, and in patients with multiple small stones inside the gallbladder. Okay? So here's an example of an intraoperative cholangiography. So that's the tube inserted through the cystic duct. So this is the right hepatic, the left hepatic, the common hepatic, cystic duct, common bile duct. So as you would see, there is no filling defect inside the hepatobiliary tree with egress of contrast medium into your duodenum. Okay? So here's another example. This one is by using a tube, and this one is after CBD exploration, making use of the T-tube as the portal for the contrast medium. So T-tube insert, insert the contrast to the T-tube. So here's the right hepatic, the left hepatic, common hepatic, common bile duct, duodenum. So no filling defect. Okay? Now, before injecting the contrast medium, we have to make sure that there is no air bubble or there is no air in the syringe. Otherwise, it will be very difficult for us to distinguish between a stone or an air bubble inside the common bile duct. Okay? So like this one. So you have a doubtful common duct there because of the presence of an air bubble there. Okay? Another one, closer look, air bubble. So if you look at it through the X-ray, it's hard to distinguish between an air bubble and stone. So you have to repeat the procedure all over just to make sure. Although there is egress of contrast medium into the duodenum, you still have that doubtful defect there. So definite filling defect. So you have there the stone. It's a small stone, that's why you still have egress of contrast medium into your duodenum. So another patient with a more definite filling defect there. So that's the stone. That's the biliary tree. Right, left, with no egress of contrast medium into your duodenum. So obviously, you have a complete distal CBD obstruction. We may also do laparoscopic ultrasonography. Okay, it is as accurate as your intraoperative cholangiography. It is less invasive, but it requires more skills to perform and interpret. Then your choledochotomy or choledochal exploration. As I've said, we do it blindly. It's either we do it by open method or laparoscopic method. And it's done if there are palpable stones or identified stones inside the CBD. That's why before doing this, we have to assess the CBD either by palpation or by doing your intraoperative cholangiography. And if it is confirmed that there are stones inside your CBD, then we open up, usually in the proximal common duct, we open up the common duct, then insert the stone forceps or stone basket inside. Well, routinely, we do it proximally first, assess the proximal area, okay? Insert the stone forceps or stone basket. If there are no stones there, then we do exploration in the distal CBD. Again, bimanually, one hand controlling the forceps, the other hand palpating from outside. Now, after we extract the stone, we flush. So we insert another tube there. We do high pressure flushing, okay? Either to push the stones down or to make the stone rebound up. We could easily harvest them. So here, diagram illustrating stone forceps inside. So it's a blind procedure. You don't actually see the tip of the stone, or the forceps rather. So be very careful when maneuvering that forceps because you might inadvertently injure or cause a true and true perforation in the distal CBD and even injure the pancreatic duct alongside. So be very gentle, be very careful when you do your CBD exploration because it's a blind procedure. Polydocal drainage procedure, either a bypass procedure or a T-tube drainage procedure. Okay? What are the indications? If the stones cannot be extracted or cleared, or in patients with markedly dilated common bile ducts. So this one is a T-tube uh, exteriorized separately. Head portion, lower, or rather head portion, lower portion. So a choledoco jejunostomy, okay, Bruin fashion. So that is the common bile duct, and this is the proximal limb or the rule limb of the jejunum, okay? And this is the Y limb. For Whipple's procedure, let's just say that we take out the head of the pancreas, we take out the duodenum, we take out the common bile duct, sometimes even the distal portion of the stomach we take out. Or if the spleen is involved, we take out the spleen. Okay? Then we anastomose after taking out everything, we anastomose first the pancreatic stump with the stump of the limb of the jejunum. Okay? It's either an end-to-end fashion or an end-to-side fashion. Then after this anastomosis, it should not be the other way around. It should first be the pancreas, then the common hepatic, and then the stomach. Okay? So pancreas first, then common hepatic, and then stomach, and then the Y limb. Okay? So again, as I've said, before doing exploration, we have to preserve the gallbladder first because it may be used later on as a conduit for bypass. So we may either do a cholecystogastrostomy, anastomosing the gallbladder with the stomach, okay, as illustrated, or a choledochoduodenostomy, okay, anastomosing the common bile duct with the duodenum, okay, in an end to side, or rather side to side fashion. Going now to case, yes, well, I think this is the 12-year-old male presented with abdominal pain, vomiting fever with history of gasiness. So this was the patient I mentioned earlier, 12-inch gallbladder. Okay. And the common bile duct was also quite dilated. So young boy with the gallbladder this long. Okay. So we also have transduodenal sphincterotomy. If you're unable to take out the stone, we may opt to do this: open the duodenum, identify the ampoule of water, try to do sphincterotomy, and then take out the stone from inside the duodenum. So the surgeon shall not engage in improper advertisement or solicitation of patients or other propaganda schemes to entice patients. Uh, this is one of the uh, phrases in the PCS or Philippine College of Surgeons School of Ethics. That's about it. Are there any questions? questions? So
No
since
questions for me.
uh,
No questions for them.
no questions, so I'll be giving the questions during the exams next time. Okay. Okay. So I think this will be my lecture, my last lecture with you guys. So good luck in your future endeavors. See you probably as colleagues in the future. Thank you.
Thank you for that.
Thank you, Papa.